here we have our 1 ml solution of hyaluronidase, which is 300 units. And I'm going to be dividing this into each of the 4 lip quadrants, because I'm going to be injecting where the filler is naturally injected into the lip body, but I'm also going to be treating above the border where we think the filler has displaced, and also in the lower lip where I suspect there's a little bit of displacement in the lower lip as well. I'm using a invisible needle with TSK, and we're just going to start with a few injections. Focusing now on the white part of the lip.
Can you feel the resistance of the filler as you're injecting?
I can, yeah, I can feel it in the upper lip in particular. If we inject here and I go through the skin, I can feel that this isn't completely mobile and smooth. Mm-hmm. This is what we call a serial puncture technique. Lots of injections of hyaluronidase to cover a large area. Perfect.
Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our Injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics. They will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like.
Now let's move to the anterior cheek, or the medial cheek, and I'm using a 50mm cannula, 25 gauge. This is sufficient to move through the deeper tissues of the midface, and I can also use the same entry point to treat the under eye with this cannula as well. So my entry point is generally going to be at this intersection between the subnasal line and the lateral canthus. It's a very good entry point generally for the medial cheek. And I'm just going to put my entry point through the dermis. I don't need to go any deeper than that. And I like to just give it 3 seconds to make sure there's no flashback. And then I'm going to use 1 entire mil, 300 units in the anterior cheek. And then I'm going to use half a mil for each under eye. As Max showed on the ultrasound scan, we know roughly where the filler is, so we're not intending to treat in this subcutaneous plane, although I may do a little bit. What I really want to treat is layer 3 itself, and I'm pushing down on that now. You can see that tethering here. The filler is entrapped within layer 3 and also just beneath layer 3, but very little product is deep down onto bone in the deep compartments. And so this mid-depth is where I want to be injecting. So if I first of all push through layer 3, we'll find some resistance. There. This is now exactly where Max identified where the filler was. And I'm going to move through, fanning into this area with threads of hyaluronidase.
And I suppose the great thing about hyaluronidase is that it spreads as well. So even if you're not exactly in one of those little filler lumps, then it will be able to make its way into that whole area.
Using my non-dominant hand here to try and create some stability for the cannula. As I move now just a little bit deeper in the medial cheek. So I've treated within and now underneath layer 3. And then I'm just going to spend a tiny bit of product in the superficial compartment as well, for good measure. So that's an entire 300 units injected into the medial cheek. And we're now going to use this same entry point to treat any migrated or displaced filler under the eye. For this one, if you could open your eye for me, Emily. Let's go again. As we approach the anterior aspect of the midface, we want to be underneath orbicularis oculi muscle. That's this depth here. And I'm gently going to fan in 0.3 mils in the suborbicularis plane. You can see the depth of my cannula here. And then I'll do 0.2 mils in the subcutaneous or subdermal plane. Perfect. Let's treat the other side now. So Max, what do you think the main mistakes injectors make when they're injecting and trying to, what can injectors do to prevent filler from going into the wrong compartments when they're injecting?
So in an ideal world, every injection you would do would be under ultrasound guidance. That just isn't possible. So technically, with time, certainly within when you're getting started in a training environment, you've got enough to think about. But I think having simple ways of knowing what layer and what depth you're in is really useful. So particularly when you're using a 22 gauge cannula, when you're subcutaneous and you lift up, you can really see the outlines of the cannula. Even now, you can see just the tip of it there. And being able to differentiate between that and being in a deeper compartment where you're moving freely and you feel that slight give after the resistance before going underneath that layer 3 or in the midface, the SMAS, knowing what that feels like is key to being in the right layer. Have you got any tips for it?
I think that's absolutely right in terms of identifying the compartments and understanding depth control. There's also things we can talk about, in terms of product selection. And if we're using a needle, we can talk about the angulation of our injection and also the bevel of the needle. And these are all concepts that we explore in our GEM framework to give people a bit more standardized structure for how to inject. Last one now, if you look upwards for us, Emily.
Aside from the dissolving, this is a really good example of how you can actually target lots of different areas from a single entry point, because from here, you could get into the deep fat compartment, you could get into the deep piriform space, you could even treat the preauricular and zygoma from here too. So
yeah,
these
absolutely
cannula treatments
agreed.
are really powerful from that perspective.
The one thing is I want to just help to demystify this is the difference between edema and overfilling. And I think this is often where we get a lot of confusion. So I would not call this malar edema. This here is the consequence of hyaluronic acid moving closer to the surface of the skin from where it was originally intended to be injected, and that attracting water and causing some puffiness under the eye. That's a separate thing entirely from a condition of lymphatic insufficiency, which will cause malar edema, which is oftenly presented here. But the overlap is that sometimes tear trough filler can precipitate malar edema. And so that's a complicated concept that we can talk about in more detail. But I often see injectors calling stuff like this malar edema, when actually it's actually the natural consequence of having something so hydrophilic sitting so close to the surface of the skin. So this is what our patient will look like after, if you just sit forward and into the camera, after the hyaluronidase. Okay, so you can see there's a little bit of inflammation, and that's because we do have a very reactive product in the tissues now, which is hyaluronidase. This is a very mild reaction, and you wouldn't be surprised if your patients had a bit more swelling with hyaluronidase, which we've seen many times. And if there is too much erythema and edema associated with the hyaluronidase, then an antihistamine can be helpful to reduce those symptoms on the first day. But what we will notice is this will very quickly settle, and by tomorrow morning, your patient will wake up, or Emily will wake up and notice that the areas that we have treated with hyaluronidase are now significantly dissolved and deflated. I'm excited to come back in a few weeks' time and we can continue the treatment plan. Does that sound good?
Yes, thank you.
All right, thanks very much, Emily. Emily, welcome back.
Thank you.
Welcome back to the clinic. So how long has it been since we did the dissolving?
I think it's 3 weeks.
3 weeks. Obviously, you've noticed some changes. So how would you describe those? What would you describe?
I think it's quite significant. Loss of volume here, around the lips, to an extent that, I mean, there wasn't a huge amount, but a little bit in the tear troughs. And I think just a whole sense of slightly collapsing.
Yes, and that's not a familiar thing after having fillers for, let's say, 10
no,
years.
No, and I'm not happy. I don't like what I look like.
So, and I think this is the teaching point, is that we have got to a stage in our field where patients have been having fillers for 10, even 20 years, and that their perception has drifted, and the filler over time has accumulated in often the wrong areas. And so having a bit of a reset like this, I think, is going to become more and more common in what we do in practice. I think the ultrasound study has been particularly helpful in demonstrating where the filler was and showing last session that the filler wasn't in the deep fat compartments or onto bone, which is what we wanted, but it was actually within the layer 3, the connective tissue of the face, or it was actually just underneath the skin. And so the opportunity to dissolve all of that, as well as the under eyes and as well as the lip filler, start again. Your patient has to be quite brave, so well done. And that's quite a lot to go through, because ultimately there is going to be a dramatic change to how you look.
Yeah.
But to have a clean slate and to build back up from then, I think is really valuable. So thank you for going through that.
No problem.
Is there anything you want to share, I suppose, to anyone who might be also in your position that is thinking about getting this done? I mean, did anyone notice, I suppose? Did anyone notice when you had the...
Do you know what? More people than I think normally would say, oh, are you all right? You look a bit tired or whatever. I think I was probably, which is always true, I think you're probably more conscious of it than anyone else. But I think people did notice, yeah.
You probably can tell, yeah.
Yeah,
okay.
yeah. It's quite dramatic, I think.
Yes, it is. But hopefully they will also notice when you get back to...
Hopefully, yeah, absolutely, yeah.
Lovely. So let's talk through the treatment plan today. Then we'll go through them in sequence. So the first thing I'm going to do is just do an overall facial assessment again, now that we have dissolved all the product.
What we learned in aesthetic medicine even 1 or 2 years ago is now outdated. Why? Because aesthetics is still a relatively new science, and the research underpinning our work, particularly our understanding of anatomy, has advanced significantly. Hello, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I want to introduce you to GEM, the Global Evidence Matrix. GEM is a dynamic, evidence-based framework that gives injectors a clear, consistent guide for safe, effective treatments, all grounded in science, not in corporate sales pitches. GEM combines clinical research, anatomical knowledge, and injector expertise, and it's always updated with the latest evidence. Think of GEM as your interactive map for facial aesthetics, guiding you through every step from technique to product choice. With GEM, you're not just injecting, you're working at the forefront of medical aesthetics. Join us in setting a new standard for safety and results.
Let's take this from the top. So Emily had filler previously significantly in the midface, under the eyes and the lips. And all three of those areas have been dissolved. The first thing that we notice, if you turn slightly this way, is we've noticed now the volume loss, particularly in the midface. Turn this way. You can see this, I think, slightly more on this side, and a lot of the filler was actually adding the structure and the volume to the midface. But the way I would describe how it was treated previously is that it was done in a very kind of generic fashion, meaning that this entire area was volumized without much appreciation of the nuances of the structures, the anatomy, the type of product we want to use, and particularly thinking about animation. And so if you give us a really big smile, you can see that Emily naturally has quite good volume on expression. And so this is something you have to understand before carrying out a treatment plan, is to understand what's going to happen when the patient has conversations, when they're smiling. And what I described last time in the video was this line of ligaments that is really important, and it traverses down the midface, separates the midface into the medial and the lateral midface. And we also then have the transverse facial septum of the zygomaticus major muscle. And so if you give us a big smile, all of this volume compartmentalizes medially and projects forwards. And so we have to be mindful of these structures when we're treating. And so when I'm going to do my treatment plan today, I'm going to be focused on how we can treat a midface like this whilst always making it look natural, particularly on expression. We also dissolved the under eye area, and we can see that that has returned. There's some shadow under the eye. It's not actually a very significant tear trough, and so I can appreciate how that could be easily overfilled and overtreated. That needs a very subtle treatment. And then, of course, the lips. The lips have been dissolved, and if you blow a kiss for us like this, often when you lose the volume that's been in the lips, we get an increase to the perioral lines. So we'll look at how we can address the perioral structures with a treatment plan today. Okay, so if you just sit forward one last time, and I'm just going to clean again, and I'll talk through how we would just assess the face naturally without thinking about any treatments. What would our facial assessment say? So Emily's main concern is laxity in the lower face. That was actually the reason she came to book in with us. What we've ended up doing, of course, is doing this entire reset. But if you just sit forward again for us, how do we actually create lifting along the lower face? Well, we have to think about our principles. So first of all, we want to work from the top down. We want to work from lateral to medial, and we want to work from deep to superficial. And so following those principles, we're not going to start treating the jawline or the lips on the first treatment. We're going to start off in the upper face, then the mid face, then the lower face. We're going to start by creating lateral treatments and then more medial treatments. And then we're also going to focus on the deeper targets before the more subcutaneous targets. And so those are the principles that I'm going to follow as we progress our treatment plan. One thing just to always mention when we're assessing the faces for symmetry, and what I noticed is there is a little bit more volume loss on this side compared to this side. So we will have to probably use a little bit more volume here than on the other side. I noticed that the brow is a little lower on this side than this side. I'm going to treat the area above the eye, this area, this supraorbital area, which I think will be a very powerful treatment for today because we lose volume in the deep fat above the eye. And by treating this A-frame, we're going to be able to lower this shadow above the eye, and that can be a very rejuvenated treatment as well. So in summary, following my principles, I'm going to start with the midface, beginning laterally, working medially, deep to superficial. I'll then treat the supraorbital and the infraorbital area, and then I'll move to the perioral zone as well. We should be using 5+ syringes of filler, all strategically in the right zones to avoid any additional overfilling or product displacing into the wrong zones. The first thing though is I'd like to see where the filler is now, if there's any left, and with an ultrasound look at where the tissues are before we treat. So rest your head back and let's have a look at those.
We're going to be scanning from lateral to medial. What we can see here is this dark layer at the top is our jelly. We've got our skin, subcutaneous fat, our SMAS layer, that fibrous layer, and then this hyperechoic white structure there is our zygoma, or our periosteum. So we can already see that there's significantly less filler here than there was last time. What we expect the filler to look like are these hypoechoic or anechoic structures, these black circles. And as I'm coming medially, if you remember last time, there were lots and lots sitting within this SMAS layer, more superficial than we would like. We can still see that there is a little bit sitting more deeply down here towards the deep piriform space, but that's exactly where we want it to be, not sitting superficially up here within the SMAS. What we can also see here, if I just lighten my pressure slightly, is this anechoic structure here, which is our facial artery. And it's compressible when I press down. And if I just angle slightly, there we go, we can see the flow in that vessel there. And that's probably sitting a little bit deeper than we expect. At this layer, at this point in the face, we expect it to be running in layer 2.